Hello everyone, I'm Dr. Juma Bishwas. Today I'm going to present one of the important topics that's called polyhydramnions, and I have taken it from TOG. Before discussing about the topics, I want to request you please subscribe my channel and press the like button, and if you have any question you can ask me on the comment box. I'm happy to answer of all of your queries. So you know that polyhydramnios is a common obstetric condition and overall incidence is 0.2 to 3.9%. However, 50 to 60% of the cases, we don't know the reason of polyhydramnios, and mild polyhydramnios mostly resolve frequently and is not usually associated with advanced perinatal outcome. Based on a normal physiological pregnancy, you can see amniotic fluid volume increasing progressively until 33 weeks of gestation, with a plateau between 33 to 38 weeks, and that followed by a decline between 38 to 42 weeks. Overall, mean amniotic fluid volume between 22 to 39 weeks ranges from 630 to 817 ml. Amniotic fluid volume, if it is above 95th centile, that decline as in polyhydramnios. Amniotic fluid production, mostly from fetal urine, and then also from secretion of the fetal respiratory tract and oral secretion, and it's removed by fetal swallowing. And amniotic fluid is dynamic across the membrane because it's transferred across the placenta, umbilical cord, fetal skin, and across the fetal membrane. Though we know that 50 to 60% cases, the cause of polyhydramnios is unknown, but these are the most common cause related with the polyhydramnios. Mostly in the maternal state, if there is any uncontrolled diabetic mellitus, if the woman is rhesus negative and isoimmunized during the pregnancy, that can also cause immune hydrocephalus. Drug exposure like lithium can also cause fetal diabetes insipidus, and that can also relate with polyhydramnios. In case of fetus, if there is any structural or congenital malformation, any chromosomal or genetic anomalies like trisomies, congenital infection like TORCH infection, macrosomia, any fetal tumor like teratoma, nephroma, neuroblastoma, hemangioma can also relate with the polyhydramnios. Placental tumor like chorioangioma and metastatic neuroblastoma can also relate with the polyhydramnios. Regarding fetal structural abnormalities, the most commonest causes are anencephalus, spina bifida, hydrocephalus, Dandy-Walker malformation, bronchopulmonary sequestration, congenital diaphragmatic hernia, any tracheoesophageal fistula, duodenal or intestinal atresia, exomphalos, gastrocasis, pelviureteric junction obstruction, sacrococcygeal teratoma. So how we will actually assess amniotic fluid volume? So usually we measure in a 4-quadrant a vertical dimension of amniotic fluid, which is cord and limb free, and we sum the all 4-quadrant measurement, and then we calculate AFI. So polyhydramnios defined as if it is AFI is more than or equal to 25 centimeter, or the deepest vertical pool is more than or equal to 8 centimeter across all gestational age. Deepest vertical pool measurement is the largest visible cord and limb-free pocket of amniotic fluid volume. So based on that, we divided polyhydramnios into mild, moderate, and severe. Mild is 25 to 29.9 centimeter, moderate 30 to 34.9 centimeter, and severe if it is more than 35 centimeter. Regarding assessment, if we see that fundal height is increasing rapidly above 90th centile on the customized growth chart, or there is a tense uterus and difficulty in palpating fetal part, we can suspect there is a polyhydramnios. And when we diagnose there is a polyhydramnios, we need to rule out the cause of the polyhydramnios. However, we know that 50 to 60% of the cases cause is unknown. Like we have to rule out the diabetes, so we need to check random blood sugar or OGTT and the glycosylated hemoglobin. It can be related with the TORCH infection, so we need to rule out that. If the woman is rhesus negative, we need to check the antibody status at booking and at 28 weeks. We have to see anomaly scan of the babies. Karyotyping, as because 10 to 20% of the aneuploidy can be related in severe polyhydramnios. Cervical length assessment, sometimes we can do to quantify preterm labor, so that we can plan for management. Regarding management, uh, firstly, we have to rule out any kind of fetal abnormalities, like we can check the weight, stomach, and the movement of the baby. If we suspected there is any kind of congenital abnormalities or any fetal aneuploidies or fetal infection, SGA or IUGA, or if there is any concern regarding movement, then we have to urgently refer the case to the fetal-maternal specialist team. We have to find out any maternal cause related with the polyhydramnios. We have to check blood sugar, torch screening, and red cell antibody. And if we find that any cause related with that, we also need to refer to the fetal-maternal specialist. We can consider steroid if we see that cervical length on the transvaginal scan is shortened. And we have to counsel them regarding the preterm labor, unstable lie, cord prolapse, APH, PPH, and also they might increase operative intervention. And based on the fetal and maternal abnormality, we have to manage the pregnancy as per that. In case of unexplained polyhydramnios, if we see that is very severe, like more than 35 centimeter, and is persistent worsening or fetal abnormality, we have to refer the case to the fetal-maternal unit. If maternal discomfort or respiratory compromise from polyhydramnios or there's a risk of preterm labor, we can do therapeutic amniocentesis or amnioreduction. In case of mild to moderate, we can do serial growth scan, transvaginal scan for cervical length. There is no benefit from induction of labor for isolated or unexplained polyhydramnios. Induction of labor we can only consider for maternal or fetal indication. We need to monitor the progress of the labor. We have to watch out for the shoulder dystocia and PPH. And even after the delivery, we have to do a thorough neonatal examination. So neonatal team should be there and they can check the patency of the upper GI tract with an nasogastric tube. There is an option that we can use prostaglandin synthetase inhibitor like indomethacin or sulindac for management of polyhydramnios, because this drug reduces amniotic fluid by decreasing fetal urinary output and by increasing resorption of the lung fluids. However, it can cause significant fetal adverse effect like constriction of the ductus arteriosus and impair renal function. So usually, as a routine basis, we don't recommend these things. So this is all about polyhydramnios. If you have any question, please ask me on the comment box and please subscribe my channel. I hope you enjoy this video. Thank you for listening. Take care.